Good evening. Welcome to Monday Night Live as we are so excited to have two special guests this evening. You're tuning in and we're going to talk about how to navigate through your surgical options and be your own advocate. Welcome. How are you?
Hi, how are you?
Good. I think we had like some technical issues. Somebody was trying to log on and all of a sudden my screen went black.
I always assume it's me, so I was like, I could see you, and then I couldn't see you, and I was trying to get on, so I'm glad we figured it out.
Awesome. How are you? How was your Monday?
Everything's good. It's good to see you. You've been so busy this month. It's incredible. I love seeing all the things you're working on.
Thank you. It has definitely been a very busy month for us, but at the same time, I'm so honored to be able to get all these packages out and be able to help so many women. But at the same time, I'm so thankful for physicians like both of you who come on during this month to make sure that we're getting the proper education, and being our own advocate. And truly, as all of us probably don't want to admit often enough, we're not our own advocates as founders and leaders. We're advocates for everybody else. So this conversation tonight really hits close to home for me. And as much guidance as I always give everybody else, I'm excited to learn from your side to how you guys see it and how we advocate through our journeys from like the physician side.
Awesome, Tracy. Well, I appreciate that because like you're right. We do take so much better care of ourselves, like of other people than we do of ourselves. And I think like learning to how you would take care of your own body and your own self the way if it were your sister or family member, daughter or mother, is incredibly important, especially, this month and every month. So we're really, really excited to be a part of this today.
Awesome. So, but as we get started, maybe you guys just want to do a short introduction. I know this is kind of round two from 2 weeks ago, but obviously, as you guys are the leaders tonight, I'd really like to pass it over to you, do introductions, and then we can get this conversation started. I know many women are excited to talk about, how to navigate and really find out your options and then be your own advocate at the same time, when you leave your physician's office or as you're sitting there, being informed when you go there.
Totally. I'm happy to start if that's okay, Zeve. So my name is Ann Pellet. I'm a breast and plastic surgeon. I work in San Francisco. I'm also a breast cancer survivor. So I went through my own treatment. It's almost 4 years now. And so definitely have very much that perspective of what it's like to be thinking about options, both on a personal and professional level. And I'm really excited to be joined with my husband, Zeve Pellet, today. We do surgery together. So Zeve, you want to jump on in and introduce yourself?
Yeah, my name is, thank you first of all for having us. My name is Zeve Pellet. I'm a plastic and peripheral nerve surgeon. And then I've been practicing for about 10, 12 years here in San Francisco, and last 3 to 4 years doing a lot of cases with Ann, and hopefully a lot of the stuff we're going to be talking about today. So really happy to be here. Thank you for having us again.
Of course. So as we open up tonight, and maybe we want to just dive right into it. And then if anybody has questions, you can feel free to send them in the comment box or send them, and we'd be more than happy to open up and answer any questions. This is kind of the advantage of doing a live. And if there's something that somebody is not comfortable asking, you can feel free to message myself, or I'm sure both of the physicians are open as we all have Instagram pages. So again, if you're not comfortable asking a question, feel free to DM any of us and we'd be more than happy to answer you. When a woman is diagnosed so first it really starts out with your scans, right? Whoever orders your scans, then your breast oncologist. And we'll take the genetic mutation out of this, even though, it's part of the cause, but for a breast cancer diagnosis, I think it's a little different, on the process of what you guys face. So, maybe you want to talk about a little bit the process and then what happens when we get to breast and plastic surgery.
Yeah, it's a really important question because, to be honest, it really isn't one I totally understood until I was in practice, and certainly understand better having been through this journey myself. And I think one of the things that we often talk about, I know you feel the same way, Tracy, is kind of you don't know what you don't know. And so I wanted to start out by saying, like, I think for a lot of people, this journey, this diagnosis is really starting with either maybe your primary care doctor, your gynecologist who might have ordered your mammogram or might have seen you if you felt a breast lump. And so I think you're really relying on this person to help you through this journey. And so my hope for people is that you have an amazing gynecologist or primary care doctor who knows you and can get you in good hands. But unfortunately, a lot of people don't have that. So if you get a diagnosis and you don't have a nurse navigator, you don't have a primary care doctor, you don't have a gynecologist, it can be really scary to figure out where to go. So I guess my first piece of advice would be is if you don't have someone pointing you in the right direction, this is the time to find your community. So trying to find groups online of other people in your situation, maybe where you live, who can help you find a breast surgeon who's going to take good care of you. And then also really looking for people who have specialized breast training. So you want someone that is ideally someone who's done a breast cancer fellowship, someone who does breast cancer surgery day in and day out, because you want someone who's up to date on all the latest technologies, the latest advances and techniques. So I think for me, that would be my thought is, first off, find a good breast surgeon who is going to get you everything you need. And second, really insist on seeing a plastic surgeon. So a lot of times we hear people who maybe didn't know about all their options, or they had a lumpectomy and didn't know you could have lumpectomy reconstruction, or they chose a mastectomy and didn't get reconstructed because they didn't know that they could do it in the same surgery. And so I really feel pretty strongly that every single person with a new breast cancer diagnosis should get to see a plastic surgeon or a breast surgeon who specializes in reconstruction, and ideally both.
You brought up a really good point, find somebody who's done cases, like who's proficient and understands what you're going through. And I think a lot of women just find out through word of mouth, who they should be referred to, or, the physician they're referred to, you Google and there's bad reviews. But, more importantly, I think there's other resources that we don't utilize, like the American Board of Plastic Surgery or the Plastic Surgery Foundation. These are all places that you can go to find physicians. And a lot of people don't talk about it. And I'm not really sure why, to be honest, because I've recently found out that it's truly a great resource. They have Instagram, they have Facebook. You can literally click on there and type in your information and it comes up with a physician. So you at least know their credentials are real, their information's real. And I think that that's really important when we talk about this, a breast surgeon or a plastic surgeon. We can all have, some of us don't have centers, some of us don't have private practices like you guys, in our states. For example, we don't really have plastic surgeons that are women in Florida. There's a handful. If you want a woman, if you want a man who's done a million surgeries, that's where you guys need to go. Look at your resources and make sure that you're reading accurate information, because unfortunately sometimes, as we know, the internet can hurt us and not always help us. So, or find your community, right? Or call an office, and if a physician is willing to tell you how many DIEP flaps he's done or she has done, that's the information you want. If physicians are not giving you that information, don't hesitate to look for a second opinion or find that community.
Yeah, I could not agree more. I mean, I think Zeev, you see Zeev and I share a lot of patients together. And I think, thinking Zeev, when you see people who come in for complicated nerve things or other things, what are the things you hope that people are asking, right? As a physician, what do you hope patients want to know so that you feel like they're getting all the educated information they need to make a good choice? What would you recommend for a consultation for people?
Yeah, I think all the things you mentioned are really good. A couple points that I would add, you sort of, Tracy, is there's a lot of sort of independent vetting agencies. A lot of people can have great websites. A lot of people can have great Instagram feeds, but you never know how real many of those are. Not to say that they aren't, but they may not necessarily be. So, for example, in the peripheral nerve world, if you are a member of the American Society for Peripheral Nerve, that is an independent vetting agency, which means you're a part of a community of peripheral nerve surgeons. You have been recommended to be a member of the society by at least 2 other members. You have at least 1 paper on peripheral nerve surgery that's been peer reviewed at some point. So for breast surgeons or for patients looking for, I would imagine, plastic surgery for sure, you can go to the American Society of Plastic Surgery. And then, if those physicians that you are interested in or have found online or through word of mouth are listed on there, you can actually find and look at their credentials. And in order to be listed there, that they have met certain criteria, they are board certified and so forth. Those are really important. The one other thing, and again, I think you guys have mentioned this already, I think it's really important when I tell my patients is find someone that you for lack of a better way of saying it, you really vibe with, someone that you really feel is listening to you, someone that understands your concerns are, what your fears are, and you feel is really hearing you and seeing you and what you are expecting and hope to get out of any plastic surgical reconstruction or any sort of breast operation, what your priorities are. And then, of course, you can ask them, and they should be forthcoming about how many of these have you done? How many of those have you done? Can I talk to one or more of your patients who've had this done? And they should be able to give you someone who, you know, looks like you and is around your age if they've done enough of those cases, as opposed to like, well, here's the one person I have done, and this is my only experience. So I think when people are forthcoming with that information, you can actually feel pretty comfortable that you're in the right place.
I think that was perfectly said. And, you know, knowing you're in the right hands and knowing that you're comfortable, right? Because this decision ultimately is your decision. And if you're not comfortable, then you need to make the best choice for yourself and be your own advocate. And sometimes being our own advocate is not easy, right? Because sometimes we know more than we should, or we think we know more than we should, or we're educated on this. But really, until you're comfortable and you can rest your head at night that you're comfortable with your physicians, I think it's imperative. And for not only breast cancer, for any kind of cancer, any diagnosis, if you're not confident in your physician, then it's not the right choice, because this is life-changing, right? Like, it's the new normal. We're going through it. You know, your physician should want to be your best friend. Like, you need that comfort and love and knowing that the new normal is going to be different.
Yeah, I mean, I could not agree more on that part of it, right? Like, it's a true partnership. And so I think, you know, I think a part of my job is to really try to get to know patients, to figure out like what matters to them. What are they worried about? You know, what part of recovery is scary? I see someone asking about, you know, what a DIEP is, and it stands for deep inferior epigastric perforator flap. And essentially it's taking a piece of tissue from your lower belly and using that to make a new breast out of. Deeps are amazing operations. They're really fantastic. You use your own tissue, but it's a really big recovery. And you really need to go to someone who does these day in and day out. There are complications that can happen. And if a complication happens, you want a surgeon that, you know, wakes up 3 times a week and is doing deep flaps. And if something happens, they're going to be the best person to take care of you. You don't want a person that does a deep once a month and think that's going to be a good choice for you. So, you know, I think what I would say is that in my thought, you know, the way that I think about these things is that this partnership, you get to ask what you need on your end to feel that comfort that you mentioned, Tracy. And so I think Zeev's questions are so key. And one of the things I recommend for people is maybe you say things that don't feel challenging, but you just say things like, this is what I would like to get to ask you to know so that I feel comfortable. So you can say things like, you know, what has the experience been like for other patients of yours? You know, like Zeev mentioned, can I talk to one? What are complication rates? Like, what are the most likely complications that happen from this procedure? And what do they look like in your practice? So, you know, I always think about nipple necrosis, which is a scary thing that can happen after a nipple sparing mastectomy. But honestly, if you're doing nipple sparing mastectomies all the time, the chance of that happening should be less than 1%. And you should get to ask your doctor. And that's what it is in practices like ours and other big practices. If you go to a place that does a lot of nipple sparing mastectomy, there should be less than a 1% chance you're losing your nipple. But you got to ask those questions, right? You got to be able to say, and you need to have a surgeon who looks you in the eye and can say, in my practice, the chance of your losing your nipple is X%. And I think a lot of times people don't put that out there, and it's hard, right? Those are hard questions when you're sitting in this room in this vulnerable place to ask for it. But honestly, I think that you got to, because it's your body and those complications are yours, you know?
100% I agree. So we have another question. I'm BRCA1 and I had ovarian cancer 5 years ago, and it's still difficult for me to go through a mastectomy, and the best options for me are deep flap or implants. And I'm going to pass that over to you, but I want everybody to know on this call, and I'm sure you guys can attest, is it's not only flaps and implants, there's flat closure, and there's options. And maybe D flap isn't for you. Maybe there's a latissimus flap or an S gap. And, you know, some people don't even know that there's other flaps available. And this all goes back to there's no gold standard for breast reconstruction. Like you can go in, you can get option A, not know of option B. But, you know, like when we go through this, we're not offered flat anesthetic closure. I've never heard a physician offer that to a woman. Like to me, now I think it's becoming a little more spoken about, but over the years it's not been spoken about. So women feel like they need to have either a flap or implants.
Yeah. It's, well, I think, and Steve and I always talk about this with sensation preserving options too, right? Like that's almost never talked about, and it's, you know, because most people don't do it. So it's the same kind of thing. Like, again, if you don't know that's an option, then you never ask for it and you were never told. And we've talked before about creative flaps. You know, a lot of people think like, oh, I don't have enough belly tissue, but I really want a flap reconstruction. I guess I can't have one. But you can potentially have one. There are flaps from other places. There are flaps from your thighs. You can stack flaps and do more than one flap. So I think this is where, in my mind, really finding your community is so helpful, because then you are in a space, you know, like the forums that you moderate, like other forums where you can hear other people and be like, oh, wow, that's a thing. I didn't even know that. Great. Where did you get that done? Oh, okay. Maybe I have to travel, but I can do a virtual consultation, you know? And then you get all these other options. You get the flat closure options. You get the fat grafting options. And so I think that's pretty amazing, is that at least you know that they exist to even know to ask about them.
And you brought up two good points. You can now do virtual, right? Which is amazing. Before you had to actually physically go to the state. Now you have virtual options as your first consult. And if you don't want to stay in state and your insurance allows you, you can do that. You know, before it was we had to fly there, you know, and then come back. But now you can do everything virtual and get everything scheduled and then set up, and then know that if there's nothing in your state available, there's organizations like ours that can help you fly from state to state. I actually just had one of your patients reach out to me that did a virtual consult with you, both of you, and they're like, I need to fly. So I just set them up today. So these are things that we didn't know about, you know, and that little piece of information that's not available out there, right, for women and even men that are facing it, you know, we need to make these known, to advocate and to look and to dig deeper. You know, and as we spoke 2 weeks ago, you know, another woman requested, I don't want the radiation that comes with a mammography. How important is it in the surgeries process?
So fortunately, everyone worries about mammograms, but fortunately, the amount of radiation with mammograms is exceptionally low. It's basically about the same as flying across the country in a plane. So really, truly, mammograms, there's a lot of controversy around mammograms, but they do their jobs and they pick things up early. So I would say, you know, if you're thinking about, let's say you know you're at high risk, maybe you have a genetic mutation and your team wants you to get a mammogram or an MRI before surgery, I would go ahead and do that, because we like to try to not be surprised in surgery. If we think we're going in and doing a prophylactic mastectomy, ideally we're not surprised by the pathology, so that we make sure we do the right surgery up front. So I would say, again, everyone worries about mammograms. It's pretty common, but fortunately, they're really, really, really low risk.
It's interesting because I think it's a constant question, you know, of how much radiation, what are we exposing ourselves to? And is it important where can we just skip a mammogram, skip an MRI, and just go right into surgery because we're BRCA? And we're like, the physicians need to understand what they're going into, because sometimes obviously you can have a BRCA diagnosis and think you're preventative and unfortunately get diagnosed. So as we talk about being our own advocates, I want to kind of flip the script a little bit tonight, as you guys are, you know, seeing patients on the other side, and whichever one of you want to start, I think would be great. You know, what would your advice be to the community as we say advocate for ourselves? What does that mean? And obviously you can answer it as a survivor and a physician, like either or, but like, what is the advice? Is, you know, everybody's like, we should be our own advocate. To me, being your own advocate means knowing what's available out there, knowing your options, making sure you're credentialed enough, making sure that you've done, if I wanted a flat procedure, how many you've done, your rate of success, Those are questions that I would think. But as a physician, what would you suggest?
So I would add one thing to everything that's already been said, which is great. And I think that the way I look at patients who present to my office is I'm a guide. I'm here to sort of talk to you about what you're looking for, what it is that you want, what it is that would be best for you. I think when it comes to options, and they can be overwhelming in terms of your number of options, and I think that in itself is scary to try and navigate. But I think it's important to find a physician who can go over all of those options for you and say, look, if you choose option A, these risks are the potential benefits. This is why this might what might be challenging in your particular case if we go with option A. You also here are the advantages to option B, and this might be the disadvantage to option B. And they should make those kind of pluses and minuses so that when you walk out of the office, you can say, okay, I went in there thinking I wanted this, and I still want that. And that makes a lot of sense, and I feel comfortable that that's the right decision for me. Or you can say, I went in thinking I wanted option A, but I think option B is better, and I'm actually very comfortable why it is that option B might be better for you. And I think, when it comes to peripheral nerve surgery, there's a lot of value judgment, pain, sensation, how much do you want, what's good, what's bad. There is no right answer to that, and what the individual person is looking for. So I think, if start off the conversation saying, look, what are your goals? What are you trying to achieve? And then you can say, look, these are 3 options. We can talk about 6 more, but these are the 3 things that come to my mind. And here's why this one might be good or bad. Help you understand that. You'll be able to leave that conversation at least with a cadre of information that you can then mull over and come to a decision by yourself, and then in cooperation with your physician. So that's
I like that very much. I think that's very much like our goal is to try to guide people and hope that they feel good about the decision. I think one of the things that for me, I think a lot about is that partnership question, but is about how can we encourage people to make sure that we're the right fit? And so we talk about second opinions a lot, right? And I think about my thought is that, are you guys hearing a lot of echoing, Tracy? Do you hear that?
No.
Okay, perfect. That's just me. That's fine. Basically, I think that for me, I think about okay, let's try to get you feeling as comfortable as you can. And that may be getting another opinion, right? That may be talking to someone else, that may be getting more information. And so the physician part of me wants everyone to feel like we are the right team for them. This is the right plan. The plan we've talked about makes sense. You heard all your options and you still want this. And I feel the same way from the patient part of me as well, right? It's like, we may not be the right fit for everyone. And another surgeon you might see might be, but that fit, that partnership, that knowing this is what I want. I've talked to your patients. I know what my experience is going to be like. I feel good about it. I feel like I'm going to be well taken care of. That's the partnership that we want. And that's the partnership we hope for all patients, whether they see us or not. So that for me is where I think your advocacy comes in. Push for those second opinions if you need them. Your role is to get as comfortable as you can with your team and with your plan. And sometimes that takes seeing more than one person.
I totally agree. What is your opinion of hybrid reconstruction? And what is hybrid reconstruction?
Great question. So hybrid reconstruction is kind of coming about more recently, and it usually means combining flaps and implants. There's some talk about kind of implants and fat grafting, and that also being a bit hybrid. But usually when people are using the term now, they're talking about people who have flap reconstruction, but maybe they want more volume. So we're actually adding implants to their flaps. So it kind of gets you the benefit of the flap in terms of you've got the nice coverage in the front over the implant, but then the implant adds the volume.
So does it give you I've heard of it before, but does it give you more of a fuller, round shaped, natural look because you're adding in an implant? Or is it a small implant? I guess what's the goal of doing that? What's the difference between just doing a flap versus an implant and a flap? Does that make sense?
It does. So usually people who do both are doing it because they feel like the amount of tissue they have available with a flap isn't the volume that they want for their breasts. So the idea is like, okay, let's say you're doing a double mastectomy and you have so much tissue in your belly and you don't want to do, a stacked flap with another donor site from the thighs or the back or something else. So you're doing your deep, you have your deep one on each side, but now you feel like, oh, I was a D cup before and now I'm a B cup. I don't love that. So then your options are to either add an implant and get you that volume difference, or sometimes people do fat grafting. So they take fat from somewhere else and fat graft into the flap. So that definitely adds volume as well, but it doesn't do so much if you want more of that like rounder projection look. Implants are really good for that.
Interesting.
Yeah,
What would
it's
you
a new
advise?
thing.
Like I've heard of it being done before, but I didn't know it was called hybrid reconstruction. And I guess now I understand the purpose behind it. If you don't have enough fat, then that's an option. But for somebody who really has enough fat, they really wouldn't need it because you can just use the fat instead.
Exactly.
Got it. What would you advise to get to a BRCA1 carrier who has been advised to have a double mastectomy?
Yeah, I mean, I think this will be great for you to answer too, Tracy. But I mean, I think one of my thoughts is like trying to figure out kind of the things we've been talking about. So first off, are you a good candidate? Do you want a nipple sparing mastectomy? It's a safe thing to do. We know that in women who are BRCA carriers, but technically, and your own concerns, is that something you want to do? So nipple sparing, non-nipple sparing. Next, do you want to have a formal reconstruction and really getting to know the ideas around implants and flaps and fat grafting? Do you want to have aesthetic flat closure and use your own tissue to kind of make everything nice and flat? And then I like to add now, do you want to think about considering options for keeping your sensation? Do you have a team who can help you with that? What are your choices? So those would kind of be my thoughts. We know that double mastectomies are highly effective at reducing breast cancer risk. They're not perfect, but they get you down to 2 to 5%, which in someone who has BRCA1 is a dramatic improvement. So I would say definitely it's a really good thing to be thinking about, but just try to know your options.
You said it perfectly. Know your options. You named them all. For women who need more advice, I know on our site, brcastrong.org, we have every option listed. Go on there. And I even suggest before you go to your plastic surgeon, or if you're in a relationship or with your husband or going through a journey, sit down and really know your options before you even go sometimes. It's not overwhelming because you're preparing yourself and knowing ahead that there is options. Again, anesthetic flat closure, implants. Some people don't want foreign bodies, foreign pieces in their body. So then you can talk about a flap. And it's not just one flap option, there's several flap options. And I think, again, really knowing those options really can make a difference in your journey on your mindset and what you want, because again, it's something that's changing in your body. That's a personal choice. So if a physician tells you, well, you have implants and you have deep, but you need to make that choice, knowing the risks for each one and knowing the surgery goals and knowing what's a process, like you said, right? A deep flap is a recovery. It can be hard, it takes longer, then now you can add in resensation. Who knew about that till I talked to both of you? Like, just really important facts. And actually, we need to add that on brcastrong.org. So we will go back on there. So we are missing one reconstruction option as
Yay.
of right now, but that is such a huge part of anybody who is either taking preventative action or being diagnosed. You don't know what you don't know, right? Like if you go out there and you're just searching, and sometimes, some of things on the internet are not what we want to hear. So, find that community, find where you can know your options. And I mean, I just can tell you, I know there's other organizations out there that have great information, and, knowing your breast reconstruction options, I think can eliminate a lot of barriers for women because what your options are. Me personally, I want to know my options. I'm sure you did too. And, after learning more about what you guys did in the resensation, I feel like again, be your own advocate, right?
Yeah, and I mean, even I know we've been talking a lot about mastectomy reconstruction, but lumpectomy reconstruction is a huge one, right? So many people don't know you cannot have this huge hole and this huge scar if you have surgeons who are able to close that space and hide your scars. You can have a breast reduction at the time of your lumpectomy, which is like a nice silver lining for many people to, you know, who've always had large breasts and always wanted to be smaller. It makes radiation easier. So I think that's the thing, like you said, is just getting in the knowing what your options are in advance, doing some research, going in, because then it gives you more space to advocate for what you want if you already know some of the choices at least, you know, and now you're just trying to figure out what choice is right for you, as opposed to going in and not knowing any of the choices. And then you might miss out on some because you don't know what they are and you're not given all of them.
Yep. Somebody asked, how do you set up travel? If anybody's interested in traveling, you can send me a DM and I will be more than happy to walk you through the process. It's painless. It's super easy. Let's
So
see.
awesome, Tracy. We're so glad you're doing that.
Thank you. Do you feel there is a size restriction for nipple sparing procedures? I'm being told a D cup is too high risk.
Yeah, so the answer is that there are definitely increased chances of complications with larger breasts. So D cup, double D cup is kind of when we start pushing it with nipple sparing mastectomy. So sometimes we'll recommend doing it in a staged fashion where you do an initial breast reduction lift, make the breast a little bit smaller, and that can help allow for nipple sparing mastectomies. But for most people, D cup is kind of right at the edge of what we would suggest from a complication standpoint.
I agree. And you know, there is somebody who just made a comment, and it's very interesting. She says it would be great for more male plastic surgeons if they would ask questions. What would you like to see versus this is what I want to do? And you know, addressing that question, and then I'm going to pass it over to you guys after that. I think it's really important that, you know, nobody's in your body. And yes, I think, and nothing biased because I've had male surgeons, if you have that comfort and connection with a female, then that's who you should see. You know, there's many male physicians out there that are very loving, that are very kind and supportive and caring. But I think it varies on your physicians. And that's where it goes back to if you're not comfortable, if your physician, male versus female, right, don't ask you, what do you want versus what they want? That should be the first red light to you as a
Yeah.
patient.
Yeah, I've seen a lot of people over the years, you know, couples will come in and the patient will, you know, say, well, what if I could wave a magic wand and go, poof, you could be, for example, whatever size, I'm talking about size that you want. And they will look over at their partner and I'll say, well, hold on. I think that's lovely that you are soliciting their opinion, but everything you just said, you know, you're the person that's living with whatever choices you make. So it's fine if you guys want to discuss it, but like, you know, really just off the top of your head, or if you about it, what is it that your personal goal is, and what would you be comfortable with? And I think that, you know, again, for so many of these things, it comes down to value judgments, and the only people that can make those calls are the patients themselves for all the reasons you've mentioned. So, yeah, I think people that tell you what you should do is a bit of a red flag for me. There are people that can tell you, again, if you choose this option, here's the good, here's where we might run into some issues, or this is what, you know, you might need to think about long term. If you choose the other option, these are the other concerns, and, you know, we will be able to achieve these goals that you want, but maybe not this other one. And again, give you that sort of blueprint so that you can choose what's best for you.
Because ultimately, everybody needs to remember this is your choice.
Mm-hmm.
No, it's not a choice that we were either passed down this wonderful mutation or diagnosed. You know, it's not, this is ultimately about your choice and what's best for you, not what's best for your husband, not what's best for your kids, what's best for you.
Yep. you can say that over and over again. I'm going to add, it's not what's best for your surgeon. Because again, I think that's a lot of, the doctor-patient relationship can be tricky, right? You're in this vulnerable place. You're with this person you're really trusting for advice. It can be really scary. And I think sometimes we get steered in directions, or we get, suggested certain things, and the reality is ultimately, like you said, it's really just what's best for you. And you've got to feel like you can say, I've listened to everything, I've heard what you've said, and I want XYZ. And you need to have a person who can look you in the eye and be like, great, we're happy to support your choice. And if you don't have that, it's not the right person for you, because, surgery isn't perfect. We all wish it were, but unfortunately complications happen, things happen, outcomes aren't exactly what we hoped for. Breast reconstruction is tricky. And so in my mind, if this is going to be a partnership, if this is a person you might be having multiple surgeries with, if you don't feel comfortable before you've even had surgery, I promise, unfortunately, that relationship is not going to get any better if something happens afterwards and you have a complication. You need a person you know is on your team and is supportive of all the things that you need every step of the way.
So can you do a DIEP and a nipple sparing?
You can. It's a great option. So definitely a really good choice for many people. Some surgeons will do it at the same time as a nipple sparing, and some surgeons will stage it and put in a temporary implant called an expander at the time of the DIP flap, and then come back and do the DIP later. But it's a great option with nipple sparing.
I think we missed one question, and I'm trying to scroll back. Did you see?
Yeah, there was something about direct to implant reconstruction, which is something I get asked a lot about. So it's a really surgeon and practice dependent question about whether or not you can do direct to implant or not. So I think there are some practices where they feel really strongly that in order to minimize complications, they're going to do tissue expander and let your skin sort of breathe for a while and then start stretching it for the reconstruction. There are other practices that feel really good about preserving blood supply and feel confident about direct to implant reconstruction. I think it's important for people to hear you do not leave more tissue behind. If your surgeon can do direct to implant reconstruction, it doesn't mean it's a worse mastectomy or a less safe mastectomy. It's just a different approach. So this kind of gets back to what are complications like? What is your surgeon's experience like? So if you say, like, can I have direct to implant? And they say no, then ask. And if the answer is, well, you would have a 25% chance of having a skin healing issue if we went direct to implant. Okay, either yes, this is your team and you're going to do expanders, or no, you feel strongly about direct to implant and you're going to pick a new team. So, but you get to ask those questions. You get to know why it is that they don't do something, and just, it's like being a mom, right? Like, because I told you so. Like that might work with kids, but that doesn't get to work as a patient, right? So
Yeah.
you get better than because I told you so. So you get to ask for yourself and you get to advocate.
A question that was sent to me earlier was, what's the difference between under the muscle and over the muscle?
All right, Steve, you want me to take that, or you want to do it?
Start out with the simple stuff, and you can dive into more of the nitty gritty. So when you place, for example, an implant, if you're having an implant reconstruction, there's two general areas with the breast region that you can use to create that breast mound, okay? And the first is you can place it below the pectoralis major muscle, big Arnold Schwarzenegger kind of flex your pec muscle. And it's where, for example, in a lot of breast augmentation cases, for aesthetic reasons, the implant is placed. It has been around a long time, has certain advantages in that it can provide an extra layer of muscle coverage. Also the ability to put the implant above the muscle, and that is a relatively newer technique, but is one that's been around for many, many years, is also very safe and has a lot of other advantages. For example, it's a lot less morbid because you don't have to lift or disinsert part of the muscle to place the implant. That has potential benefits for long-term sensation. It also mitigates the need for something called a hyperanimation deformity, where if the implant is under the muscle and that pectoralis muscle flexes, that implant can move in ways that it might not normally do and certainly in ways it doesn't move if it is above the muscle, which seems to be a more anatomic location to place an implant. So I don't know if you want to add other things, Anne, but
You did a great job. I think it's definitely a really big topic that is, very hot topic in breast reconstruction. I do think this comes back a little bit to many plastic surgery practices have evolved to going over the muscle. I would say that's definitely a newer, kind of more evolved, more advanced technique. And so this is another one I feel pretty strongly about. If you do see a surgeon who tells you they want to go under the muscle, you get to ask why, and what are the downsides to that? And why don't they go over the muscle? And why might not you be a good candidate for over the muscle? And so I think really getting an explanation, and the explanation of, oh, this is just what we've always done, isn't good enough. So make sure you get a real explanation about why for you that wouldn't be a good choice, because I do think most practices are moving or have moved to over the muscle.
It's interesting how far technology has really come. I must say, and the advances that we have made. Because again, 6 years ago, we weren't doing over the muscle, at all. I mean, I do have a silly question. When was the first DIEP done? When was it created? When did it become popular in the US? Because 6 years ago, I don't remember it being the talk of reconstruction. Did I?
Yeah, so I mean, I think the DIP flap sort of in the 2000s, were kind of when the early to kind of mid 2000s were when people were really starting to get going and doing them more often. But the reality is more people are talking about it, which is great. And I think there are a lot of deep surgeons who are pretty vocal on social media and other places about what they do. But the reality is in most non-major cities in this country, you probably couldn't get a deep flap because you do have to have such specialized training. So while deep flaps are amazing, there are very few places in this country that truly do them very frequently and very well. So it's an awesome option, but it's still a little bit limited in terms of who offers it.
What are the downsides to over the muscle?
Yeah, so I mean, I think most of us who do one over the muscle all the time feels like the answer to that is very, very few. So one of the things people talk about is rippling, seeing the edges of the implant through your skin. Usually that happens on the top part of your implant based on how they sit when you hold it in your body. And so the thought is, well, if you had muscle over that, you wouldn't have rippling. Well, that's true. Every time you contract your muscle and you get that thing that Eve called, which is called hyperanimation, you actually see very significant rippling, if you will. It's just rippling of your muscle and not of your implant. So I guess for me, what I would say is that either way, both under or over the muscle, do have some challenges in the upper part of the breast and often need back grafting to help smooth out that spot. So for me, I find if that's the only true downside of over the muscle, but it's not really that different than under the muscle in terms of a downside, and the benefits, all the things you've mentioned, long-term outcome, pain, naturalness of the implant well outweighs being under the muscle.
mm-hmm.
Do you want to read the next question and answer it? Because it's definitely for you.
Yeah, so someone's asking us about training other people or about who else is doing sensation-preserving mastectomies. So the short answer is that it's coming. There are more places that are doing it. It's been really exciting. Eve and I have been on some conference calls with some other centers. Cleveland Clinic, for those of you who are from the Midwest or East Coast, is a great example of a group that's really actively working on trying to do more of these. They've got a great team approach. We're really looking forward to starting some preceptorships to train more surgeons. We've been out there in our virtual world tour, giving grand rounds and teaching surgeons and making videos and really trying to get people learning. So it's coming. We love having people come visit us. We're so grateful, Tracy, for your supporting people to come see us. But honestly, I hope for everyone that you don't have to come travel to come see us very soon, just for your own sake and not having the disruption of having to travel. So it's coming, hopefully next year. I think really within a year, we're going to be having this kind of live, and it's going to be surgeons all over the place are doing it.
That's truly amazing. That's groundbreaking, right? Total different technology.
Yeah, for a number of reasons too. I think one of the paradigm shifts here is, for example, when I was a resident a long time ago in my plastic surgery training, the sort of paradigm, and it was that the breast surgeon was in one room doing the mastectomy while the plastic surgeon was doing something else in another room, and then when the breast surgeon was finished, the plastic surgeon would come in. And I think the one really lovely thing about our working together is that in order to get the really good results that we're seeing with our sensation preserving techniques and sensation reconstruction techniques, is that both parties, so to speak, have to be involved really from the get-go. Because as you're doing the mastectomy, the nerves are in the line of fire, so to speak, and sometimes they can be preserved, and that's wonderful. But it is at this point out of the scope of training for most breast surgeons, any breast surgeons, to try and find and preserve those. And sometimes the nerves are passing right through the breast tissue, and obviously for oncologic reasons or for prevention of cancer reasons, that nerve has to be severed at some point. But the idea is to preserve as much of it as you can before you have to cut it, of course, being oncologically safe, and then doing it in such a way that you are able to reconstruct it such that, and at the time of the operation, so that the ultimate sensation is really good. So I think it's a really nice paradigm shift, not only in terms of the technology, in terms of the results and what we're able to offer for patients, which are most important, but it's also a new way of surgeons of various kinds working together to really achieve those results. And I think it's something obviously everyone can feel good about when all is said and done, which is great.
I think maybe we want to take 1 second, if you guys are okay with it, and like, this is, a continuation of our call too from a couple weeks ago, but like maybe just go over like what resensation is and explain to the community again, as we've had a lot of new listeners just tune in, and make them aware of that this is even an option.
So I think, sure. I think that we have a couple different things. So the first one is this concept of resensation, which is traditionally actually been done for a long time in some practices of when you have flap reconstruction. It's usually done with deep flaps. You can actually take a nerve from the flap that you harvest from your abdomen and connect it to nerves in the chest. So that's a great option for people who've maybe already been through their mastectomies. They know what it's like to be numb. They bring these nerves up and bring back your sensation in your chest. And it's pretty remarkable. And Resensation has some really great discussions of this. If you go to resensation.com on their website, and patient stories about having sensation in their chest restored with flaps after the fact. The thing about that, though, when we're having this conversation about options, is that for many women, flap reconstruction isn't the right choice for them for a variety of reasons. So currently in this country, 80% of reconstructions are actually implant-based. So we really felt like it was really important. I know you're like, your mind is
80%?
80% are implant-based.
I heard that, right? Like 80?
80.
Wow.
So thank you for sharing, Annie. I'm just highlighting one of our comments from one of our wonderful patients on there. Thank you. So what we're super excited about is trying to have the option of nerve sensation return for all people, whether you're having implant reconstruction, flap reconstruction, no reconstruction, flat closure. So what we try to do, and what we've developed over the last few years, and some other groups around the country are starting to do this, as we mentioned, is trying to preserve nerves that can be safely spared, meaning they don't run in the breast tissue. They have to run in the fatty layer because we want to do a good mastectomy. We want to do the safe thing oncologically. So if nerves can be kept, we try not to cut through them. We try not to cause the chronic pain that can come through and numbness. And then for nerves that can't be saved, we'll reconstruct them in the same surgery. So this, again, can be done with implants. This can be done with flaps, flat closure. And so what's really exciting is starting to see people who are now have this option of truly getting back most, if not all, of their sensation. And we're talking sensation in the nipple, sensation in the breast skin, responsiveness to touch. We have people who tell us that their breasts are able to still be involved in intimacy and sex, and they feel when they have clothes on, and they feel when they have sports bras on. So it's really exciting to see how this has taken off, and it's incredibly wonderful to have our patients who've gone through this share their experiences, so that people know that this is a possibility now and know what to expect, and know that they can take on prophylactic surgery, take on double mastectomies, and not have to worry about having their entire chest be numb afterwards.
I would imagine that helps with the whole process from like a mental aspect. I must say, like when we're told, we're going to lose the feeling of our breast, right? Like, do we really even process that the right way or internalize it until it's too late, right? And you're like, wait, what happened? Or you're leaning up against somebody, you don't realize, oh man, my breast is touching them. Like the things that you don't realize that are really imperative and play a really big role to know that this step can change that, which I'd imagine would help so many women process it mentally.
And also your implants,
I lost you.
like if you have implants or flaps, oh, sorry, like making sure that you know your implants or flaps like are part of your body, right? It's hard adjusting to something, especially if it's an implant that's foreign. I think implants can feel cold. You know, it's a lot too. Like you said, the psychological part of it is really real. And then I got a really lovely message from a friend of mine who she had a mastectomy, not with us, but she actually did get sensation back just on its own. And that can happen. It's just unpredictable, but she has a lot of sensation come back. And she had a baby recently. And she sent me this message saying like how incredible it is that she holds her baby and she can feel his hands on her chest. And honestly, in my mind, I think about like, those are the small moments, right? Like we all know, Tracy, you know, I know, Zeev knows because he went through this with me. Like it's so disruptive. These things that happen to our body that we never wanted and we never planned. And here we are going through all this. And I think anything we can do, whether it's hiding scars, saving nipples, you know, neat ways of reconstruction that minimize what downtime, whatever it is that we can do to help us minimize the disruptiveness of this on our lives is so important, and something that I know Zeev and I like would fight for every single day for anyone we could to make sure that people can minimize how hard it is.
Yeah, and one of the most powerful things that I will still never forget, we had a patient come from New York and had been diagnosed with BRCA several years earlier, and of course every 6 months or so has some kind of imaging study, and you have a week of agita where your fingernails off, not knowing what the study is going to show, and do I have cancer now or not. But she was at a certain point in her life where losing sensation was just really not an option for her. She literally didn't want to do. And in the office, I'll never forget when she said this, she's like, I've been waiting for someone to invent this concept, invent this technique so that I don't have to think about cancer anymore. And I think, you know, it's one of those things that will probably stay with me for my entire career, because I think, yeah, it's such a cool part, and it's so great to have, you know, yet another option that we can offer to patients, and yet another way to potentially minimize sort of the long-term effects of their treatment, because, you know, thankfully for a whole host of reasons, you know, a lot of women live many, 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 many years after their diagnosis. And so we really need to try to minimize the long-term effects of whatever that treatment is, because you have to be in those bodies for a long time.
I think we need to minimize how many surgeries women have too. Like I think that's a really big misconception in like what we go through and the inner battle as well as outer battle. But a mastectomy isn't a boob job, really. It's not. Like there's no way that you can compare it. There's no way, like when women make comments, I'm like, this was not a free boob job. Like you can't even compare you putting in implants to what I've been through. And I think minimizing that effect for women could also be a life changer. It can, all right, I can't talk about it. Let's talk about, you guys can take that conversation over.
I know, it's
that hit home.
I feel like the same thing. And I'm going to be honest with you. Like, I know it's a lot. And I see, I know you're going through a lot right now and trying to minimize surgery. And I think, you know, the way that I see it, we're in this amazing time where we're literally like the three of us are on right now talking about like how we can do amazing things to help people feel good and look good and feel like themselves. And that's incredible. But we're also still stuck that mastectomies aren't perfect and reconstructive surgery isn't perfect. And I know it takes a really big toll, and I know you're going through a lot right now. And I appreciate your being out there and sharing and still advocating for women, even when, you know, emotionally you're going through so much around this right now too. So I'm incredibly grateful for you for making space for everyone else at a time that I know is hard for you.
Absolutely.
You know, I don't want anybody to ever face like, it's real. Like, you know, I really haven't shared a lot about my story or what's going on. And when the time is right, I will. But, you know, my journey has become my passion, and knowing that there's so many other women out there that are suffering in silence. You know, we need to share, we need to educate, we need to support, we need to be kind, we need to know our options. And I just don't think that sometimes people really understand what you're going through or how to process it, and like the mental and emotional toll that it also takes. And I mean, you going through it as a survivor yourself, I could only imagine, what your concerns were. You're in the field, right? Like what's going to happen and the unknown.
Yeah, it's really scary. I feel every day like it's incredible to me that people trust us with surgery and trust their bodies and go into an OR. And I know all of that is so scary. And that's why we're really lucky, honestly. Like Zeev and I, we all connected, I was so grateful, Tracy, because honestly, like for us, this is our dream, is to have people out there who are also like as passionate about getting other women and other people all the information they need to make good choices, to know that we have a support group out there. We have a community. I know that if I had anyone who needed help and had questions, we could always have them check in with you. We feel the same way. I feel the same way personally. So I think that's all of us can do, is just be there for each other and help everyone get the very best care, and hopefully get better care than we had. Even if our care was great, we still want everyone to keep evolving and have better options.
100%. And it always changes, right? All of us know that it always changes, and the differences that we can continue to make. And, as I sit here and I say, in 1994, they found the gene, right? 2004, I was diagnosed, and I look at, and I literally say to myself, like, in 2004, like I was told to go on tamoxifen. We weren't even talking about mastectomies yet for us, who just carried a genetic mutation. And then they started, talking about all these options, and, just to see the advancements and the difference in making sure, again, that we're here to educate and just continue to do that no matter good days or bad days. Like I won't give up. Like BRCA Strong is my reason. And, today I sat here and I packed packages, and you keep going, and I don't want anybody to suffer. I don't want anybody to feel that they're alone. Tears are normal. I normally don't cry on Instagram Lives. I promise you this. But, we're human. And I think that certain times we're more vulnerable, and, we don't want to talk about it. But when you're together in a group where that, and I know that I can just say, listen, go see this team, they're going to make the difference, think about resensation, think about your options, think about, the narcosis rate. Like you told me that, and I'm like, I can't believe that you shouldn't have a failure rate of that. Like it should be 1%. Like I'm still mind boggled because I hear women all the time talking about it. And I'm like, is it your body? Is it your physicians? Is it the centers? Like you never know when like infections come up. Is it the doctor? Is it the infection? Is it, is it you? What's going on during this process?
Yeah, no, it's so many things. But again, I think this is why I'm so glad we're doing these kind of things. And I think that, the humanity, the vulnerability, the things that we share about our journey, this honestly, it lets people know they're not alone. So again, I think for you, people are going to watch this, they're going to see this, they're going to see your realness, see that you're going through this too. And again, those are the times that we connect with people and know that we're not alone. So thank you for that, Tracy.
Definitely. Thank you guys so much for coming on tonight. As always, it's a true pleasure, and we will definitely be back on, continuing just to be advocates for you, for us. We all learn from each other. And most importantly, breast cancer is not just October. It's 365 days a year, 24 hours a day. And we are here to support you at BRCA Strong. And if you are in need of a pre-mastectomy care package that includes a robe with drain holders, a bra, 2 mastectomy pillows, or our program Bras for Brave Beauties, which is lymphedema sleeves, prosthetics, post-mastectomy garments, or if there's any support or anything that we can help you with, you can feel free to reach out to myself, as well as if you were in South Florida, this Saturday, free mammogram event. Don't miss this appointment. Free mammograms. And right now, just so you guys know too, we have partnered with J Screen and Amona. We are offering 25 free genetic testings with the partnership of getting genetic counseling. So if you or your family member need any of that, please feel free to reach out to us or follow us on Instagram. And thank you so much again for tonight, and we will be in touch soon.
So awesome, Tracy. Thank you so much. So good seeing you. Thanks for having us.
Thank you guys. Bye-bye.
Bye.